So my name is Robert Zeiser. I'm here at the EHA meeting 2019 in Amsterdam, and I present some novel findings on graft-versus-host disease and some developments in the field also of graft-versus-leukemia activity. Allogeneic hematopoietic stem cell transplantation is a major therapeutic intervention for a majority of patients with acute myeloid leukemia. For those patients, chemotherapy is often not curative, and allogeneic transplantation can provide an immune effect that then leads to cure of those patients. However, there are important side effects of allogeneic transplantation. Those include infections and graft-versus-host disease. Graft-versus-host disease is a serious complication. It affects mainly the intestinal tract, the liver, and the skin. Prophylactic measures include the use of T-cell depleting agents like ATG or post-transplant cyclophosphamide, but also immunosuppressive standard drugs, including cyclosporin A or tacrolimus as a backbone, and then combined with methotrexate or mycophenolic acid. Novel developments have been made in the field of the treatment of steroid-refractory graft-versus-host disease. This is a major complication because patients who do not respond to corticosteroids then have a high mortality after allogenic transplantation with a 1 year survival of around 30 to 35%, so it's a serious complication. And in recent years, a lot of novel approaches have been tested and developed from the preclinical model into clinical trials. Those include, for example, the inhibition of Janus kinases 1 and 2. Recently, in the FDA approved ruxolitinib as a JAK1 and 2 inhibitor for the treatment of corticosteroid-refractory acute graft-versus-host disease. A while ago, the same has happened for corticosteroid-refractory chronic GvHD, where ibrutinib was the first approved treatment. The immunosuppressive approaches have to take into account that you also want some immune activation because you need control of the leukemia, and this control of the leukemia is brought about by the allogenic T cells. In patients who are beyond day 100 post-transplantation, relapse is a major cause of death, and therefore novel strategies to interfere with leukemia relapse and to promote T-cell activation are urgently needed. Recently we could show that inhibition of FLT3 ITD downstream signaling with sorafenib leads to the production of the cytokine IL-15, which promotes graft-versus-leukemia activity. This is just one example in a certain type of leukemia, but here at the EHA meeting, novel drugs that interfere with the anti-apoptotic BCL2, for example, in leukemia have been presented, and it is important to take those into consideration when you think about maintenance therapy after allogenic transplantation or about treatment. Those include patient and leukemia-specific approaches. For example, IDH1 and IDH2 inhibitors are under investigation, have been reported to induce remission in a certain percentage of patients. Others are BCL2 inhibitors, MDM2 inhibitors are investigated, and those are combined with the standard treatments of acute myeloid leukemia, being demethylating agents, chemotherapy, and stem cell transplantation. So it is an exciting field. You have to take into account when you treat graft-versus-host disease, yet you need some activity of the donor T cells, and I'm very much looking forward to see the future developments in the coming years.